again, everyone. I hope you're enjoying lunch or about to be able to enjoy your lunch. We're going to keep going because we have a lot to cover. But at this time, I would like, if there are any members of our OSBEP board present, would you please stand and just let us know who you are and give us a wave. OSBEP board members. Okay, thank you. At this time, I'm going to tell you about Tian Rose. So I'm going to give a little bit of a background. In May, OSBEP accepted the resignation of Tian Rose, who had been our executive director for almost 16 years. She leaves a lasting impact on psychology licensing rules, regulations, procedures, and her expertise has been invaluable. Her efforts for budgetary responsibility, managing complaints, and legislative testimony while maneuvering collaboration with other state agencies. Tian represented psychologists at the onset of the Oklahoma becoming a SIPAC state. She also worked diligently the last few years helping facilitate reciprocity agreements with Texas Behavioral Health Council and helped to enact statute with collaborative partnerships and interests from neighboring states. On behalf of OPA and the OSBEP board, I'd like to present Tian with a presidential citation. So Tian, would you join me while I read the citation? And her husband, Chris, is here with us today. Hello. All right. So in recognition of your outstanding dedication, hard work, and commitment to OSBEP and the collaboration with OPA over the years, we celebrate this milestone and sincerely thank you for all your years of wonderful service. Thank you so much.
Thank you. Thank you so much. It's been an honor to work for the board, and I appreciate everyone in this room. And I think I've worked with almost every one of you, if not the majority. So I could never say how much I've appreciated and enjoyed my experience. And I hope to continue some type of partnership or something and just stay in touch. Please don't not stay in touch. Thank you.
Okay, don't go anywhere. I also want to invite Dr. Sternloff up to offer some words about Tian Rose. Oh, yeah, you're so welcome.
I asked Dr. Ward to come up here. She's not currently on the licensing board, but served 2 terms, a little more than 2 terms, I think, on the board. And no one knows Tian better than Dr. Ward. I had a great opportunity to work with Tian for several years as a board member, and then over the past year or so as chair of the board. Tian and I would talk quite a bit during that time. She would message something, or quite often there'd be a phone call that I would have on the way home to discuss a board matter or something with ASPPB. I remember in April, the 1st of April of this year, Tian said, I need to talk to you. And I'm thinking it's about the ASPPB conference. And I said, okay, fine, I'll call you on the way home. And she said, no, let's do a Zoom instead when you get home. And that should have been my first clue. And we did talk about ASPPB, and we talked about several other things. And then as I thought we were wrapping up, things kind of lingered a little bit. And she said, well, and it hit me right then, oh my gosh, she's going to resign. And she told me she was going to resign. And I was very happy for her, but ended the Zoom call and started thinking about it. This was April 1st. And so I messaged her back shortly after. I said, is this an April Fool's joke that just went way too far, Tian? And she said no. So I was disappointed, but she's been remarkable, and her service to the licensing board and to all of us as psychologists is more than commendable. And we have a little, I can't take the credit for this. Our new executive director is handling everything, but we have a little something for Tian, and really appreciate her. And I'd like Dr. Ward to say a few words too.
It does not take much to get me to talk. Okay, so I want to tell you guys just how hard the executive director's job is. She deals with, and Jenny now deals with, an ever rotating board of personalities and people that she's answering to. And she has to learn the rhythm of the different psychologists on the board. And she has to make sure that we're following all of the rules and the guidelines. But wait, don't stop there, because Tian represents Oklahoma, or represented Oklahoma at ASPPB conferences. So she would be at those big multi-jurisdictional meetings. But wait, she was also the chair of all of the executive directors across the US and Canada. She was numero uno in terms of, and everybody elected her because she's fantastic. So I need you guys to know her reach is far and wide, but she certainly, she's been a great executive director, and I hope we will be forever friends. Did you get a picture? Oh. I'm not really part of this. I'm gonna hide right here. Do you want some help here? Okay. Yeah, best wishes on your signatures.
Yeah, let's give another round of applause for Tian Rose. And best wishes on your next adventure. Okay, at this time, Dr. Rogers, I'm going to turn the program over to you. Thank you.
We're going to be a little more casual, I guess. They brought a table up here for us, which is fine with me. So we want to say welcome back. And for this presentation, we have brought together several experts from around the country to help us better understand the clinical presentation and treatment consideration for PANS and PANDAS. We'll have both in-person and virtual presenters, and then we'll have some time for question and answer at the end. First, I'd like to introduce our panelists, and then in just a few minutes, I'll let them tell you a little bit about themselves and kind of where they are, their expertise, and different things like that as we move ahead. First, to my right, this is Amy Cross, and she is a nurse practitioner, APRN. She is located locally here in Oklahoma, and she does have some expertise in working with PANS and PANDAS, but I'm going to let her tell you a little more about that in a few minutes. Also, virtually, we have joining us Angela Henry, LCSW. Angela, if you can hear me, give us a little wave up there. She's in the top corner there. And she, I believe, is in Indiana, but she, again, they'll tell you a little bit more about themselves when they each are visiting with us. And then we have Karen Lamb, Dr. Karen Lamb. She is a psychologist in Florida. And Dr. Lamb, thank you so much for coming today. Dr. Lamb and I got to talk on the phone a little bit whenever I was doing some other research for my son. And so we so appreciate that all of our panelists are willing to come. And then we have Sarah Van Alstine, and she's in the bottom corner here. And Sarah, I met because we're on some state committees together, one of the quality assurance committees for managed care and some different things like that. Sarah is here in Oklahoma. She's an occupational therapist, and she is president of CODA. She'll tell you a little more about that, but that's sort of like OPA for psychologists, that's for OTs. So we're happy to have her here in kind of a multidisciplinary approach as we talk about this. So before we get started with our panelists and let them introduce themselves and go into their areas of expertise, I wanted to set the stage for you just a little bit about why I feel like this is such an important topic, and why I just feel like we as psychologists and mental health professionals and those working with children and adolescents should be more aware of this. So I am going to tell you a little bit about my story and the story of my son. And so what I did, I went ahead and typed it up as I was kind of going through thinking about what can I say, how can I explain this 4-year journey. My mind started to go all over the place, and I was very avoidant about it. And so finally I thought I just need to focus and type it. So I'm going to kind of read it. I don't always present like that, but for today, I felt like that was the best strategy. So I want to tell you a little bit about my beautiful son, Samuel. We call him Sammy. Sammy is the most sweet, loving, fun, funny, brave boy you will ever meet. He is also the most strong and resilient boy. From his second day of life, when he went into the NICU for 49 days until today, he has defied all odds and proven himself spectacular. Sammy has always been very happy, a happy kid full of life, easygoing, sometimes overly compliant. His occupational therapist told me you need to teach him to say no, that he has a voice, that he has a choice. But the story I want to tell you is about one that started in the fall of 2021 after Sammy turned 15 in April. That fall, it was as if someone turned the lights off and everything became dark and I could not find my son. Initially, he had very restrained eating. He began to have tremendous spike in anxiety, a lot of separation anxiety that he had never had before, some OCD type symptoms. He began to regress, started wetting his pants, which he had never done before after he was potty trained. In a very short period of time, he began to get aggressive, hitting himself, hitting others. There was just a horrible decompensation, and a downward spiral took over. Anxiety and regression increased. He was in tremendous pain, but not able to describe what was wrong, what was hurting, what was happening in his body. He began to bite, pull hair, bang his head on the walls and the floors. At some point, we thought he was having seizures. At times, he became catatonic. He would break things, rip outlets out of the wall, destroy cable boxes. Literally, our lives, our home was being destroyed. He lost 88 pounds. We had 29 broken out windows. We had to build a crazy system of locks and bars and walls to protect him and protect us. Once on a Zoom call with the pediatrician, she said, "It looks like you live in the county jail." I said, "It feels like we live in the county jail." My husband and I had to sleep and eat and work in shifts because one of us had to be with Sammy every moment for safety's sake. We removed all loose objects, light fixtures, virtually everything from our home, except a few pieces of furniture that had to be screwed into our 110-year-old original hardwood floors. That was a devastating day for me, let me tell you. We had almost no outside interaction. He couldn't go to school. We couldn't go to church. We couldn't go to the grocery store. My husband eventually had to quit his job to stay home full time with him because we couldn't have people in our home, not even families. Doctor visits became our only outings. countless visits to our pediatrician, 4 gastroenterologists, 3 neurologists, 3 endocrinologists, eventually 3 psychiatrists, 2 nephrologists, 2 geneticists, a CPS referral, an APS referral, and the list goes on. 3 wrong diagnoses, one of which led to 10 months of a wrong medication, a $12,000 a month medication. I was very fortunate that my insurance covered that, but often for these treatments, insurance does not recognize PANS and PANDAS enough to cover treatment. We came to find out that that was a wrong diagnosis and that the medication they were giving him was made of the thing he had the most highest sensitivity to, which then created a later problem that it took months and months and months to recover from because of wrong medication. I said, if Sammy, let me go back here. Finally, at my insistence, back and back and back to the gastroenterologist because he continued not to eat. Her recommendation was, well, if he won't eat, I've diagnosed him with anorexia now. If he won't eat, he will have to have a feeding tube. And I said, ma'am, no ma'am, we won't do that. We need to find out what's wrong with my son. So she finally agreed to do another scope, at which time she told me I was incorrect in my diagnosis. There's not an enzyme deficiency. I don't know what it is, but we can take him off of the medicine. There was a lot of damage to the gut from the medicine, high levels of yeast, and again, that was another battle we had to fight later. Finally, over 2 years into the hellish journey on one of our many ER visits, 2 by ambulance, after one of many CT scans, the ER doc said, I have no idea what's causing these problems with your son, but he has so much inflammation in the gut, I'm going to give him an antibiotic at least. We came home exhausted, which had become our default state, but within 3 days, Sammy started to feel better. He started to perk up. And within 10 days, it was like he was cured. And I thought, what first line, front line, $15 antibiotic miracle is this? And so we thought it was over. We thought whatever was wrong had been cured by this miracle augmentin. And we had a few good months, but then things started to go off the cliff again. I called the pediatrician. I told her we need some of the miracle augmentin. She was about as desperate as we were after all this time. And so she said, well, it won't hurt. Let's try it. She called it in, same response. We did that 4 times over the next year, every time with the same response. And we would have a few good months and then off the cliff we would go again. Eventually, we spent 5 full days at the Mayo Clinic with 21 separate appointments, and no one could tell me what was happening with my son. 5 days and $5,000 later, the disposition of the Mayo was, we have no idea what's going on with your son, but we don't think you're crazy, Mom. Keep looking. And at that point, it was almost worth the money because you start to think, am I crazy? Is this really happening? What is going on? So we continued to look, and the Mayo Clinic asked me if they could put him in some studies they were running and if they could continue to be part of the treatment team. And of course, I agreed to that. So we came home, and let's see, where am I? Shortly before we went to the Mayo Clinic, we had to make an emergency room visit. He was subsequently admitted. They gave him, I don't even know, I don't know, lots and lots and lots of medication to try to sedate him. And I met with a psychiatrist. I really liked him. He was a nice guy. I think he's a very good doctor. But he came to me and very gently started to explain to me how I was basically in denial. These are my words, but that was his sentiment. That I was basically in denial, that my son had autism, that this is just how it was, this is how it was going to be, that I needed some relief, my son needed some relief, my family, I needed to be realistic, and he needed to go on an antipsychotic for behavioral issues. And for a split second, I considered it because I thought, eventually one of us is going to have to be medicated because we just can't live like this. But I said to him, I know how to sedate him for my convenience. but that will just cause him to suffer in silence. So we're not going to go that route. And I kept saying, something is attacking my son. Something is going on with my son. I know autism, I know psychosis, and I know my son, and this is not that. We tested him for parasites, heavy metals, a brain tumor. Um, if he had been a neurotypical teenager, I would have been tearing his room up looking for methamphetamine or some other illicit drug. So many times I shudder to think, what would have become of my son and where would he be today if I had not had the resources that I had, or the knowledge that I had, or doctor in front of my name? In the early summer after the Mayo visit, which was preceded by a round of Augmentin, or we could have never made the trip, we had a young ABA therapist come to the house to see about some summer programming. We were still kind of in the sweet spot after the Augmentin. And I'll never forget that beautiful girl. She had pink spiked hair, numerous tattoos, several piercings, and she was truly a godsend. I told her what had been happening over the past 3 years, and she said, "Have you ever had him tested for PANS or PANDAS?" And I said, if I've heard of that, it's so remote, I don't remember it. I don't know what that is. But immediately I went to my friend Google and pulled it up, and he met every criteria. I was stunned. I could not believe, after all the specialists, all the time, this was an answer. I called the Mayo Clinic that very day and I said, I think I have an answer and I believe it's PANS and this is why. And I was kind of met with this flat, well, the Mayo Clinic doesn't treat PANS or PANDAS, but like, thanks for calling, And I thought, okay. So I continued on then to vigorously research what was this, what could I do? At least we had a name, we had a diagnosis to explore. I thought this was going to be the answer to our prayers, and literally thousands of prayers. And some of them that ended with, if it's never going to get better, just let us come on to heaven. But we didn't, and he got better. Having a diagnosis, I thought, would finally bring closure to the journey. But alas, that was only the beginning of a new arduous journey. We found a doctor in Oklahoma City who made the official diagnosis, had some success with her, didn't work as well as we had hoped. But we continued to research every treatment, anything that seemed to have promise, anything from plasma exchange to frozen donkey milk. And there are lots of things out there that, who knows? Along the way, I came across the name of a world-renowned researcher in the area of pandas. They even have the protocol for testing named after her, which is the Cunningham panel, Miriam Cunningham. And would you believe she's at OU, University of Oklahoma in Norman? I thought, oh man, this is amazing. I couldn't get her contact information, but Rachel Funk Lawler, who's here, I saw her somewhere, she helped me find this woman. And I finally got a hold of her. She called me back. She did give me some ideas on testing, but OU doesn't really treat PANS or PANDAS. And she's a researcher and doesn't do the treatment. So we were kind of back to square one. Finally, about the end of in December of 2024, the American Pediatric Association came out with an article that said, in essence, we do believe it's a real thing, but we think it's pretty rare. But it did start to open the door, and even the DSM-TR has a mention of it in conjunction with OCD behavior. I personally believe it's probably more prevalent than we think, but that's me speaking as a mom. I'm in these circles now, and so I'm very aware of it. I see it. So I don't know, maybe it is very rare, but maybe not. Again, I was looking as a mom, not a scientist and psychologist. So one of the things that I really got my attention as I was looking, I did find a clinic at the University of Arkansas Children's Hospital in Little Rock. I contacted them and there was a voicemail and she said, this is Sandy with the PANDAS clinic at the University of Arkansas Little Rock Children's Hospital. And I thought, I'm just going to cry that somebody even knows the name, much less a whole clinic that works with this. But they wouldn't accept us because we lived out of state. Probably would have moved there, but the waiting list was too long. But they sent me all the protocols. They sent me everything they could. And because I was a psychologist, they felt very open to share information with me. And, you know, I think back, I can think of probably 4 kids in my very recent work, within the last 8 years anyway, that probably this was the diagnosis, but I didn't know what it was. Some of them went to inpatient and probably are still there. You know, I don't know. But again, after all of this came to be, and I thought, you know, people will come to us as psychologists, as psychiatrists. It's a neuropsychiatric disorder. And me, I didn't know anything about it. And I thought maybe my colleagues don't know enough about it either. So that's one reason I wanted to do this presentation, because a lot of parents and children that suffer with this don't have the resources we do. They don't have the knowledge we have. They don't have doctor in front of their name. They don't have somebody to call somebody to get somebody's name to give you a number. So we are a frontline defense. And so for that reason, I wanted to present this today and tell a little bit about my story. Now I'm going to kind of step aside and let our experts talk to you from an expert perspective. And so first up is going to be Angela Henry, and Angela's an LCSW. And so I'm going to let Angela take it away. And then I think Amy will go next, and then Karen, and then Sarah.
So we can move to slide 7 on whoever is doing the slides. But while we're doing that, I just wanted to say, Dr. Rogers, thank you so much
Emily, we can't hear her.
Oops.
One second. Angela, turn it up.
Sure. I am unmuted. Can you hear me? Can you hear me now? Hello? I shall sing and dance for you. It looks like Dr. Lamb can hear me. Can anybody else hear me? Anybody else? Hello? Hello? Anybody?
Angela, I'm going to go see if we put the microphone by the computer. Maybe we can hear it.
All right, super.
And while Angela's coming on, I just want to say Sammy's doing great. We have a new physician who's doing some homeopathic, and he's doing great, wonderfully well. And I'm so, so thankful for that.
Checking out the sound.
Oh, it would actually.
Can you hear me? I am on and ready to go. On slide 7.
Okay.
Can you hear me now?
No.
Anybody?
Okay.
Okay. Can anybody hear me? Checking 1, 2, 3. Checking. I am sending lots of love to Dr. Rogers, who just shared the most beautiful story, and I would like to comment on it when I can.
Yeah.
Hello?
Get back to up there. Okay.
Hello? Dr. Rogers? No problem. I'll just hold tight until you are ready.
And
Yes,
Angela,
yes.
we're gonna let Amy go ahead and go.
Okay.
And flip to her slides, and then we'll come back when we get the technical support up here, if that's okay. Okay. Emily, can you go to Amy's slides? Amy, you go ahead and introduce yourself.
I think better on my feet. You take a breath here. I'm just getting over the cold of the century. Anybody else have, oh my gosh, this one was, this was a killer cold. I am honored to be here tonight, this afternoon. What time is it? Is it afternoon still? Driving from Oklahoma City to Tulsa is something I rarely get to do, but it seemed like it took me forever today. And I think it was because I was afraid I was going to be late. But just a wee bit about my journey, only because I think it's relevant to what we're talking about today. I've been a psychiatric nurse for 44 years. And about 12 years ago, I was doing psychiatric home health with chronic, seriously mental ill patients. And I really, really liked it. But all of my patients smoked. And as a recovering nicotine addict myself of many, many years, I was sick all the time. And my husband and my doctor said, find another job. So our Walmart was not hiring. So I went to a temp agency and said, if you have any long-term placements, let me know. It was on a Friday. I got a call on Monday that said, how would you like to work in a lab? And I said, well, nobody's going to be smoking there. So fine. So I walk in on Tuesday to Madeline Cunningham's lab and begin a venture that would, at 72, take me back to school. I became the nurse for Moleculera, this is my disclosure, Moleculera Biosciences, used to just be called Moleculera Labs. And all that Moleculera offers is a blood panel that will provide evidence of autoimmunity. And basically, the highest and best use of this panel is to differentiate between patients who have primary psychiatric diagnoses and patients who have psychiatric symptoms secondary to an autoimmune condition. And that's all it is. And so for the last 12, almost 13 years, I have worked in that company. I am just part-time, transitioning to a consultant because at 72, I went back to school to get my nurse practitioner degree. And a year ago, I opened up my own practice precisely because of what Jadine said. There are very, very few providers in any state. If you're not in Massachusetts and you're not in California, it's going to be really hard for you to find a provider unless you have an inside track. You have a friend whose child has been diagnosed. You have that rare, knowledgeable doctor. So I decided I wanted to take what I had learned over the past 12 years and begin to be able to be part of a treatment team for these kids. So that's how I ended up here, because I responded to a post Jadine put out on the Oklahoma PANDA's parents group, looking for someone to fill this slot. So that's why I'm here. I think it's important to know, and probably this is a good order for us to go in, what happens to a kid who is neurotypical, perfectly normal, functioning at top notch one day, and he goes to bed and wakes up the next morning in the exorcist syndrome. And I have heard many, many, many parents use that phrase. It's just like, they expected the kid's head to start spinning around and vomiting green. because it is not their child. This is a child who wakes up unable to put on their clothes because of sensory sensitivities, can't stand the sound of certain people's voices, refuses to go to school, and on and on and on. We'll talk about, you'll learn many more of those symptoms today. So why does this happen? The mechanism behind this is called molecular mimicry. And this slide is somewhat useful, but what it boils down to is a person gets an infection. We all get them. We get an infection. Our bodies are programmed to produce antibodies. That's a good thing. This is what we want to have happen because it's the antibodies that go around our body killing the germ, killing the pathogen. In certain people with a genetic predisposition, we believe, to autoimmunity or to a more permeable blood-brain barrier, those antibodies that are designed and programmed to look for a pathogen, an infection, will breach the blood-brain barrier. Let's say, for example, the pathogen is strep. There's no strep in the brain unless you're in ICU and intubated. There's no strep in the brain, but that antibody that is programmed to kill strep gets through the blood-brain barrier and it circulates, doing surveillance, looking for something that looks enough like that strep pathogen to warrant an attack. Unfortunately, in the basal ganglia, which is a very small structure in our brains, but responsible for an awful lot of stuff, receptors in the basal ganglia have what we call homology, enough similarity to the strep pathogen or whatever germ the person's dealing with, that the antibody says, aha, I have found it. And it may just be a tiny genetic sequence, could be just three little proteins, some amino acids, but it's enough to warrant an attack. When receptors in the basal ganglia are attacked by these antibodies, you're going to get a whole host of symptoms, and we'll talk about what some of those are. This is just a cartoon. This is the germ. Here is this guy with the pink spots. The antibody is programmed to look for something with pink spots. It gets in the brain, and lo and behold, something in the basal ganglia has pink spots. So it goes ahead and attacks. I think do I change or can? You can try it. So this is the basal ganglia. It's the globus pallidus, the substantia nigra, and one other little piece. What is it? Globus pallidus, substantia nigra, and one other piece. I'm not a brain scientist. You guys are. But you can see it's very small and it's deep in the midbrain. And these are some of the things that the structures in the basal ganglia control: movement, memory, habit formation, procedural learning, balance. So you're going to have a kid who's emotionally labile with tics, vocal or motor tics. And I have to tell you, I didn't realize until I went to work in this field that 2 of my 5 kids were PANDAS kids. They met all of the criteria. I'd never heard of it before I started working in Dr. Cunningham's lab. But, and I probably was too, and there are probably many of us in this room who had a similar experience. My tics absolutely drove my older sister crazy. She begged my mother to make me stop, but I couldn't, nor could my kids. So balance, these kids will be bouncing off the walls. They will experience academic decline, particularly in math and handwriting. Their memories will disappear. they can't, this is what I remember with my son, I would say, take your clothes up to your room and put them away. Well, he'd pick up the basket and then he'd look at me. You know, the sequence just wasn't happening. So that's what happens. That's where it happens. What's the next one? So I think this is important because a lot of us get hung up in the nomenclature. In the late 90s, Dr. Sue Sweeto was working at NIH in the developmental and behavioral pediatrics program. One day, with kids with all sorts of problems. One day her lab tech said, you know, my son's tics stop when he's on an antibiotic. And that's what started this whole darn thing, because it was an aha moment. Dr. Sweeto started treating certain kids in her cohort with antibiotics. And just like Jadine's experience, his kids got well. So that led to the understanding that we have today that this is an infection-triggered autoimmune neuropsychiatric disorder. The relationship, PANDAS was the first thing that was given an acronym. The S in PANDAS stands for strep. The P is for pediatric. Well, we learned pretty quickly, it's not just kids and it's not just strep. So there are other acronyms. My favorite is ITABI, I-T-A-B-I, and it was coined by Dr. Ken Bach in New York. Infection-triggered autoimmune brain inflammation, because it really describes what's going on. But PANDAS is in the common vernacular, but we know it's not just peds, we know it's not just strep, so we had to come up with something else that would cover that, but also account for all of those other cases where the cause was mycoplasma pneumonia or Lyme disease or herpes virus, particularly Epstein-Barr. So we called it PANS, Pediatric Acute Onset Neuropsychiatric Syndrome. So that's the umbrella. PANDAS fits under the umbrella. So that's one of the things I wanted to make sure that we talked about today. And the next one, as with all of our patients, treatment begins with a thorough history. I mean, speaking to the choir here, because I was a psych major in college, and I married my statistics professor. How dumb, you know, it's like, what's all that about? Back when it wasn't cool to be doing those kinds of things. So a thorough history, a comprehensive assessment, totally everything, family history, back to what was it like when they were born? What kind of delivery did they have? Were there any problems at birth? Appropriate laboratory testing. And this is probably a subject for debate, but from my experience, the appropriate laboratory testing involves identifying what the infection is. When I see a new patient, and they haven't had labs, or they don't have an MD or a DO or somebody who's managing their medical stuff, if it's brand new to me and that falls on me to do, I order strep testing, mycoplasma testing, quantitative immunoglobulins, because if their immune system isn't robust, their response on antibody tests are not going to be robust. So you have to scale those things forward. I like to know if they've had mono. And the thing that you all see lab tests, I'm sure, on your patients, because you're part of a team. So you're going to see lab tests, and what your doctor is going to miss is an unusually high IgG. So when we have an infection, we produce an IgM antibody. And that I learned this a long time ago. M is for immediate. That means you have the infection now, or you've had it recently. IgG is gone. The G is for gone. The infection's gone. You've had it, but it's gone. You're over it. But if that IgG is unusually high, like 2-3 times higher than what you would expect in a recovered patient, that's a treatment target, and doctors miss this 99% of the time. So something to look out for, because that can often be the offending organism. Multidisciplinary treatment planning. Oh, forgive me, ruling out medical causes. That was rule number 1 when I went to school. You rule out medical causes before you start labeling psych conditions. With this disorder, you have to rule out some of the things that you all dealt with. Some doctors take that to the extreme, and they want an MRI, they want a lumbar puncture, they want all sorts of scans and things to rule out other stuff. There's a case to be made for that, but if you had a previously healthy kid who was going to school, playing with their friends, eating their food, sleeping well at night, and they're suddenly not okay, there's probably something other than a long-standing medical problem going on. But we have to rule those things out. Applying targeted therapies. One thing I really want to share with you, because we may not all be in on treating, at least from a medical standpoint, but we all are in on diagnosing. The website, PANDAS Physicians Network, it's pandasppn.org. It's non-commercial, nobody makes any money on it. It's carefully vetted. The information on that website can be trusted, not totally non-commercial. And there are wonderful flow sheets for both treatment and diagnosis. So I refer parents to this website, providers to this website. It's great information. All of the literature that has come out since the 90s on this disorder is housed on that website. So if you need a citation for something, that's the place to go. We'll talk about some of the therapies. Of course, you evaluate the response, and then you think your kid's out of the woods. They go back to school, everybody's happy. They're eating, they're sleeping, they're getting along with the family. And it starts all over again. And that's what we call a flare. And one of the things that I have learned from people who have taught me about this illness is the trick to managing a flare is early intervention. My favorite drug in the whole wide world is azithromycin. I just cannot tell you the utility that it has in this population. Now, it's not for every infection, but strep and mycoplasma are going to be the causative organisms, probably 80% plus every time. And azithromycin not only kills germs, but it's anti-inflammatory and it modulates the immune system. So you get a 3-function drug in one. And if your kid doesn't have cardiac issues, it is one of the safest drugs on the market. So managing flares is early intervention as soon as and it's the moms who will catch this. The dads might, but mostly the moms. The first tick, the very, very first symptom, I don't want to put my shoes on. My socks feel funny. That's as simple as a flare on its way to becoming a full-blown disaster. So early intervention. Okay. I always think of treatment of this disorder, and we all fall on here probably in various spots. If you think of it as a triangle, the first thing you have to do with these kids is find out and clear whatever infection caused the problem. If it's strep, that's usually pretty easy. If it's mycoplasma, that's walking pneumonia, by the way. If it's mycoplasma, it's usually pretty easy. If it's one of the herpes viruses, it's not so easy. We try antivirals. There are all sorts of therapies that you will not find in a drug compendium that are used in other types of therapies, homeopathy, naturopathic remedies, herbals, botanicals. That's as important as those things are. That is not my jam. I'm learning, but I'm not proficient in that at all. But there are lots of ways to clear an infection. No matter what you do for that patient, if they're still infected, it's not going to work. None of the therapies that we're familiar with are going to work. None of the immune modulating therapies like IVIG or Rituxan or which is a chemotherapy drug, or plasmapheresis, where you clean antibodies out of the blood. They're not going to work because that infection is going to clone out antibodies every 3 weeks. So you have to clear the infection. At the same time, you want to dampen inflammation because this is an inflammatory process. These kids, you heard the phrase brain on fire? If you haven't read the book or seen the movie Brain on Fire, I recommend it. However, Susan Cahalan, who is the subject of that book and the movie, she had a different kind of encephalitis. She had an NMDA receptor encephalitis rather than a dopamine receptor encephalitis. So you have to kind of parse that out a little bit. But you dampen the inflammation. And it is incredible what a dose of Aleve will do for one of these kids, or a dose of ibuprofen, or ibuprofen 2 or 3 times a day for a couple of weeks before you have to give their little tummies a rest. Clear the infection, dampen the inflammation, and then you may never have to modulate the immune system. IVIG is $12,000 a dose, and it is not usually covered by insurance. So in my experience, I have talked with, my job with the company is talking with doctors and parents and helping them find resources. I've talked with hundreds of parents who have lost their homes. They've lost their 401ks. They've had to borrow money from everybody they know to be able to treat their kids. To me, that's a crime. So I won't get off on that soapbox, but these kids need treatment. Unfortunately, the treatments are at this point expensive. But if the infection clearing and the immune modulating or the inflammatory medications are not useful, then we have to look at immune modulation, to just like rebooting our computers. You give a child, you flood their system with healthy antibodies from about 1,000 donors, and it causes their immune systems to just cascade into, let's get rid of all these antibodies, and we hope that the bad goes out with the good. So that's the importance of being able to do that. Now, while all this is going on, you have a kid who is screaming, yelling, hitting their parents, hitting their siblings. I'm trying to think of my patient list right now, what all they're doing. The list goes on and on and on. These kids are really out of control. They're dangerous. I've had kids stab their grandparents. I don't mean to sensationalize it, but these kids can be very, very violent. They jump out of moving cars. They jump off of, 3rd-story windows because their brains are on fire. So while all of this is going on, we have to manage their symptoms. We have to keep them safe. There is a role for Antipsychotics sparingly. I use them only for safety. If I have a kid that's going to hurt themselves or hurt somebody else, we have to stabilize their mood. That's my go-to. Typically, Abilify is all you need. Sometimes even just 2 milligrams. But anyway, we have to manage symptoms, and there's a million ways you can manage symptoms. Some of it's behavioral, and some of it's medical. So I think that might be my last slide, is it? No. I've covered some of this already. The problem with me is once I get started talking about this stuff, I cannot quit. Only because I see it and hear it every single day. I have seen families fall apart, people get divorced, kids get sent off to who knows where, and it's a tragedy waiting to happen. So I provided this because it goes through the antimicrobials, anti-inflammatories, immune modulators, but symptomatic treatments. CBT is the only thing that has an evidence base for helping these kids. It's the only thing that has an evidence base. Low dose SRIs, specifically low dose Zoloft. I start my kids on 12.5 milligrams of Zoloft when OCD is their primary symptom. Zoloft has really good evidence for dampening the obsessive compulsive cycle that these kids get into. And as I said earlier, mood stabilizers. So, most important slide of all. No provider of any type can do this by themselves. It truly takes a village to treat these kids. Most of the time, before a child, this is a survey we did in 2018, before a child gets an accurate diagnosis of an autoimmune neuropsychiatric disorder, they have seen between 5 and 15 doctors. So one of my goals is to decrease that number so people can get their kid or themselves, if they're an adult. We have many cases of adult onset. I have an 87-year-old lady who got COVID, cognitively intact, driving, going to church, perfectly normal, and now she can't leave her house. She's crippled by OCD. And the insurance company doesn't want to, Medicare doesn't want to cover IVIG for her. So this is just a list of all of the people that are typically involved in a case. You know, one of the hallmarks, as you'll learn here in a minute when I finally shut up, so one of the hallmarks of this case is ARFID. These kids will have absolute food refusal for a whole variety of reasons, typically not body image. And they get into trouble. They need nutritional support. Some of them need refeeding. So it's a non-discriminatory disease. Everybody needs to be on board. So that is my last slide. Thank you for putting up with my voice and my stories and letting me be here today with all of you.
Okay, can you guys hear me? Can anybody hear me? If you cannot, you can hear me? Great. I'm so excited. I feel like I need to rewind, but I want to say thank you first to Amy. That was just a wonderful presentation and slide deck on such great information. And I know we're going a little bit backwards, and that's okay. I also wanted to say thank you to Dr. Rogers for sharing your vulnerable story with us. And it is so, so difficult. And I wish that I could say that your experience is few and far between, but unfortunately, your experience is a lot of caregivers' experiences, and it's heartbreaking. And so I'm so glad that we're doing this presentation so that you can become more educated and have ways to be able to screen and understand these disorders a little bit more, because we need to do better. As you can see in both um, Amy and Dr. Rogers' talks, this goes oftentimes unnoticed, even by some of the biggest and some of the best. And again, we can do better. So, real quick, just for the sake of time, my name is Angela Henry. I have a private practice in South Bend, Indiana, and specialize in OCD and tics, anxiety, BFRBs. And then because of those things, I started getting more and more clients that looked a little different. And lo and behold, those are my PANDAS clients. So if you treat kids, if you treat adults, if you treat people with OCD and or tics and or eating challenges, you've probably seen a lot of these kiddos and maybe you haven't even known it. So, there are a lot of different kinds of post-infectious and or immune-mediated neuropsychiatric challenges, as we can see on this slide. But for the sake of going back a little backwards from Amy's work here, we're going to look at two types. And again, that's PANS and PANDAS. These diagnoses look psychiatric, as you've heard, but the basis of them are medical. So think of these diagnoses as, wrapped up in a package, medical diagnosis wrapped up in a package, though, of neuropsychiatric and typically what seems like to be behavioral symptomology. It's important to remember that both of these diagnoses are clinical, which means there's no single one lab or biomarker to confirm them, but the diagnosis is based on medical findings and observable behavioral and neuropsychiatric symptoms. So this is really what makes, and we can go to the next slide, but this is really what makes those conditions different than other purely psychiatric conditions. So the first one that we're going to look at is PANS. And again, these have really long, challenging names. It stands for Pediatric Acute Neuropsychiatric Syndrome. And we say immune mediated because this really refers to how the body's immune system is responding to an infectious trigger, an injury, a toxin. There are so many triggers for PANS, but we're seeing symptoms not because of the specific virus or infection, but really because of how the immune system is responding to that specific thing. So PANS is considered a syndrome because there is a set of medical signs and symptoms that tend to occur together. And when we're looking at PANS, there is a specific medical sign, which we'll talk about in a moment. But the criteria for PANS is an onset of OCD. And again, just like and Amy said, oftentimes we say in this world right now, sudden onset, because that's what we see from some of the research, but that's not always the way that it shows up. So I'm kind of changing my language to say there's an onset at some point of OCD and or restrictive eating intake with at least two of the following symptoms that you can see to your right. And then we can go to the next slide and we're going to look at PANDAS. And again, another long, complicated name. So it's better just to say PANDAS, but it stands for Pediatric Autoimmune Neuropsychiatric Disorder. And this time it's associated with a strep infection. And this is a post-infection, and it's also immune mediated, meaning that we're referring to symptoms that don't occur during the infection itself, but it's after the infection has already occurred. And again, we're looking at how the body's immune system is responding to it. Research is saying that typically there needs to be, for most people, 3 or more infections to have the almost like epigenetic response turned on. So pandas, I think, like Amy had mentioned, is a subcategory of PANS. And again, pandas is considered a disorder because there is a recognized pathological process, and that is the group A strep. And again, sometimes when we think of strep, we think of just like a sore throat and the oral type of strep, but it can also look like anal strep. It can look like skin infections such as cellulitis or impetigo. And even though we don't hear about this a lot, it can look like scarlet fever or rheumatic fever also. So again, there's an onset. Sometimes it's sudden, but there's an onset in this disorder of OCD and or tics, and then at least 2 of the challenges to the right. Now we can go to the next slide. So in our most recent information, I was at IOCDF, International OCD Foundation's conference last summer, and Dr. Sweeto, Frankovich, and a lot of others were able to come and speak. And while we know there are so many different ways that symptomology can look for these kiddos, they were able to do more recent research and really look at the heavy hitters. And so I wanted to look at what these heavy hitters are, and you can see those in the slide. So oftentimes, 98% of our clients with PANS and or PANDAS show emotional lability. 95% show separation anxiety. 90% of these kids are going to show handwriting challenges with margin drift. That's kind of where, that's the neuropsychiatric piece where you're going to kind of see it go off or down off the page. And 90% will show changes in urination, sometimes with accidents like Dr. Rogers described. They may previously have been potty trained, but then all of a sudden they're having accidents at night. It can also look like increased and more frequent urination. And then 80% are going to show you this just hollow kind of terror-stricken type facial expression where you'll hear physicians and parents talk about, like, my kid just, like, there's nobody there. They're just kind of blank inside. But in addition to these heavy hitters, oftentimes, even though this is a product of PANS, we're going to see that restrictive eating or the ARFID. And this can look like we know there's 4 different types of ARFID right now, but this can look like selective eating and or refusal, can look like a lot of different things. And this can also be a product of the OCD. Maybe your kiddo is scared that they're going to choke, and it's really a function of OCD, but it's labeled ARFID because they're not eating. Hallucinations are another piece, and this could be visual, auditory. We're also seeing these kiddos have sensory sensitivities. I think I heard Amy say, like, if you see a sudden onset, it's so easily missed, or I guess we're going to say onset is so easily missed because it could be as gentle as my socks don't feel right, I think is how Amy described it. And that's a sensitivity. So we might see that. We're going to go to the next slide. We're going to talk a little bit about prevalence in the next couple slides. But right now, honestly, the research is all over the place. Research is showing the rate of incident with PANS and PANDAS being like Sweeto refers to it as 1 in 200. And then Wall did another study in 2023 from 3 primary care centers, and it's showing a prevalence or incidence of 1 in 11,765. And as you can see, that's a huge difference. And that's really highlighting the need for more research. And I know even in my own little town where Notre Dame is here in South Bend, Indiana, I have probably 2 handfuls of kiddos that I'm treating with more and more being identified. So anecdotally, I would say that obviously the incidence is much higher than 1 in 11.7 thousand or so. So it's not as rare as some of the research, in my belief. It's not as rare as the research is suggesting from WALD, but I kind of liken it to autism. And the more research we've done, the more education that we've done for providers and for just the population, more kids are being identified. And I imagine we're probably going to see the same thing with PANS and PANDAS as well. So as we look at the study by Wald, and then also Stanford did a 10-year study, we can see that that mean age of diagnosis is pretty similar. Age 6 for Wald and 7.1 for Stanford. There really isn't a lot of difference when we look at diagnosis between males and females. And in terms of ethnicity, the Wald study showed 100% of clients were identified as non-Hispanic. Caucasian and Stanford study showed 85%. But I'm guessing this is more likely where the research locations were completed. And we know access to care is a challenging thing because, as Dr. Rogers mentioned and Amy mentioned, the cost of treatment is astronomical. So I wonder if more of the identifiers in terms of, who's Caucasian, who's Hispanic across ethnicities is more of an access to treatment. We'll go to the next slide. So here we're talking a little bit more about prevalence, especially when we're talking about eating disorders or the eating challenges, ARFID. And we're guessing that most likely the prevalence that is being shown right now is probably an undercount of cases because we're having a hard time looking at the samples all together because if we're looking at 50%, 52% of the people screened with PANS, this is looking like over half of the young people diagnosed with PANS are showing that restrictive eating, especially if it's sudden and severe. So we're actually experiencing, of those people diagnosed, they're actually experiencing neuroimmune driven symptoms consistent with PANS. And why this matters is the abrupt onset of restrictive eating might be misdiagnosed as a typical eating disorder when it's actually part of the neuroimmune condition. So PANS related eating issues often stem from the sensory challenges, fear of choking, which might be more attached to the OCD, contamination fears, or other OCD related stress. So really the bottom line here is that the findings highlight that current prevalence estimates for pediatric eating disorders, they're significantly underestimated because clinicians aren't looking at this specifically. We're looking at OCD or we're looking at tics, but we're not looking at it in a comprehensive way, and so it's incomplete. And I think I have one more slide, and then we're going to get to the wonderful Dr. Lamb. But as we're looking at familial risk factors, there are a lot of studies done. You can see at the bottom of the slide there, but the studies by Frick, Frankovich, Johnson, Sweeto, and Ma all give a really strong evidence of increased vulnerability with families related to the immune-mediated neuropsychiatric conditions. So children with PANS and or PANDAS often come from families with higher rates of autoimmune illnesses, inflammatory conditions, OCD, tics, anxiety, immune system problems, and other relatives with PANS-like symptoms. So it's not uncommon in our office for siblings then to be identified as having PANS, PANDAS, or both, parents having a history of autoimmune conditions. So PANS, PANDAS is not random. So we're seeing this epigenetic kind of response, biological and genetic vulnerability that runs in families. So I am going to hand it over to Dr. Lamb to go through things that clinicians should know. And she is a smart cookie, so you are going to want to listen to her.
Thank you, Angela. Thank you, Dr. Rogers. Thank you, Amy. This has all been super exciting. I love talking about this. I am a licensed psychologist in the state of Florida. So I don't know if in Oklahoma you've had a cold snap, but we have. And when we have a cold snap, we have a warning that iguanas will fall from the tree. And it's been cold here, but it's warming up. I'm going to talk about things related to mental health professionals, and there's going to be some overlap from what Amy talked about with what Dr. Rogers talked about and what Angela Henry talked about. But I'm going to try to go through it fast because Sarah, who's going to talk after me, she has some really awesome things to say from an OT perspective. So next slide, please. One of the main things I want to highlight is sudden onset, what that means to us as psychologists, as clinicians, and changing symptoms. Then I'll go into flares and I'll talk about multidisciplinary collaborations and what do mental health clinicians need to do to get these groups together and help these families. Next slide, please. As we mentioned, the DSM-5, when you look up PANS, you're not going to find it. However, if you look a little bit closer, what you might find, or many of you who are diagnosing a child who comes to see you, you might say that they have OCD due to a known medical condition if you know that known medical condition. However, sometimes for these families, we don't know the underlying condition that is creating these neuropsychiatric symptoms. And that can be very impactful for that family. One, we might not find the right medical interventions. Two, they may not be diagnosed because we're really not sure what's going on. And three, as clinicians, we might be treating them psychiatric or mental health side and missing the medical side. And we'll talk a little bit more about that. Just to sum up, next slide, please. To sum up, what we're all here to talk about is we are talking about post-infectious immune-mediated syndromes. And I want to talk about abrupt. Next slide, please. Over the past 4 years, the amount of research related to PANS and PANDAS has been exponential. And I chose these case studies because there are many case studies in the research. 13-year-old boy in England in 2020 went to the hospital after he had COVID. They did a nasal swab, tested positive for COVID. 2 weeks later, he had these neuropsychiatric symptoms. And if you've ever given the child Yale Brown obsessive compulsive scale, he scored a 28 on the SIBOX, which means he had a severe level of OCD. This is a child who did not have these neuropsychiatric symptoms before he went there. So 2 weeks after infection, this is a child that had motor tics, vocal tics, hyperactivity, aggression, irritability, inattentiveness. And he was seen, and they were able to start to do medical treatment, and they also got him right into psychological treatment. Yet 3 months later, he still had symptoms. And I say this because if you Google PANDAS, PANS, you're going to find a lot of case studies. You're going to find a lot more research that's really giving us a clearer picture. But COVID in particular has given us a lot of information about how COVID has impacted certain people. And I just like to highlight this because oftentimes we don't realize that everyday infections that we assume people will get better from, we realize that some of the people aren't getting better. Next slide, please. Sudden impact also means, so for that family, they went in 2 weeks to their child having severe OCD, and that severe OCD means more than 3 hours a day, more likely 6 hours to nonstop. This child was doing compulsions with arranging. You can imagine how that has an impact on the family. As Amy mentioned, and as Dr. Rogers mentioned, multiple medical appointments when you see your child change so dramatically. Miss school, what's that impact on miss school, communicating with the school? You can see how very quickly parents and caregivers can get overwhelmed, or sometimes we say they might even get burnt out. Besides that, we also look at the siblings. Siblings really can be isolated in this process if they're trying to figure out what's going on with the impacted family member, but also they are at a higher risk of becoming, having PANS or PANDAS. So sometimes we just start right in doing what we know. We might start doing parenting training. We might start doing the models that we know, but sometimes families are getting told that they're just bad parents, and that is the absolute wrong message we want to send. We want to first check in when sudden onset comes. How's that family doing? What's going on for that family before we even start to do our usual treatment models? Next slide, please. This is an example of caregiver burden inventory. And the reason I put it here, you can imagine with a sudden onset of neuropsychiatric conditions, and as Angela described them, it's a constellation. If your child's not eating, if they have a high level of OCD, if they are having changes in their urinary functioning, that can really lead the parent to have to change how they are interacting with their child. And I always think of these cases in the intake. We should really see how is that family doing? How is that parent doing? They might not come to you immediately. I'm fortunate. Sometimes I get kids literally. They were diagnosed January 5th with PANDAS, and I might see them January 8th. That's like such a short time frame for us to do medical interventions and for me to also be helping that family decide what kind of interventions we might be doing. But I am not doing therapy with a child that soon into their treatment, but I am setting things up for when the child is ready for it. Next slide, please. What's a flare? You will hear families talk about flares, and I think this is one of the important things because everyone's just describing a flare a little bit different. Our friends at Stanford in the Stanford Immune Behavioral Health Clinic, they looked retrospectively over the past 10 years of the kids who came into their clinic. Now remember, the kids who go to Stanford, they have a research-based clinic, so they have a criteria that they're looking at, but they were able to give us a working definition of flare: abrupt or dramatic onset of neuropsychiatric symptoms and functional impairment. Like, sounds so easy. Then they started looking at how soon was that neuropsychiatric symptoms starting? Was it within 3 days, 3 to 7 days, 2 weeks, more than 2 weeks? Because that can help us understand a little bit more about that child's immune system. And they did something super clever. They defined the end of a flare in their families based on clinician report and parent report. What they found is a lot of parents would say, my kid's almost better. They're almost there. They're not quite there. And I see Sarah smiling there because I don't want to say a flare is over unless we're back to baseline. And that's a really interesting part of collaboration. Listen to parents. Incorporate what the parent is saying to you. Next slide, please. This is what Stanford proposed in their working group of defining flares into 4 categories. A single flare: a kid gets sick, they go through treatment, the immune system responds, they go back to baseline, single flare. Persistent, primary persistent, all right, they get sick, but this is chronic. So after 12 months, the kid is still showing signs of neuropsychiatric symptoms, relapsing and remitting. These are the kids who you are looking at. They have a flare, they get better. Oh, in time, they have another flare, they get better. Something like that, that it is coming and it is going. And finally, the secondary persistent, they got better after the first flare, second flare comes along, but they don't get better. It becomes a chronic issue. Next slide. Why that matters is because we need common language to describe flares. And something that Stanford found is on average, a flare lasted 4 months. I think that's an interesting piece of information. Not every kid's flare is going to last 4 months. But if you as a clinician are thinking 4 months, it sure can help you think about how you're going to provide treatment. And it might be able to help you support that family in a different way. What I will tell you is flares don't go away immediately. There are some secondary neuropsychiatric symptoms that may stay around. And those are where we might be very good at treating or helping support the family. As Angela mentioned, in the Stanford study, they found the average age for the kids was between 6 and 8, which is interesting because a lot of the kids they didn't see until age 11. So that is several years after their initial flare. But they did very good detective work trying to find out from pediatricians and all the records, when did this flare start? Sometimes when you're working with a family, and you say, hey, has your child ever been sick? Did they have any neuropsychiatric symptoms afterwards? I don't think so. Well, maybe, but we just moved. Well, I'm not quite sure. It can get really blurry. And that's important for those kids who have those first flare, but they stayed chronic. They didn't return to baseline. We might actually be seeing some of those kids in our practices thinking it's just OCD, but actually they might be a PANDAS or a PANS kid. And so sometimes chronic symptoms, I actually tell people, look closer at the beginning. See if you can find a pattern there because you can really change lives. It is really remarkable when you as a psychologist are working with families and you're like, wait a second, this separation anxiety is more intense. They're really holding on to you. What do you mean that our behavioral techniques aren't working? And then you're like, oh, this is a PANDAS or a PANS case. Let's help you here. And then your treatment actually becomes more robust and much more helpful. What they did find in Stanford is the majority of the kids had relapsing and remitting patterns. And us as clinicians, one of the things we can do for families is really help them track these patterns because it can help you with the medical interventions. Sometimes we use Excel spreadsheets. Sometimes we do some other things. And I'll talk about that in a second. Next slide, please. This is a shortcut. And if you notice, diagnose, the right after that is medical treatment. And medical treatment is part of what Amy was describing, what Angela was describing, what Dr. Rogers was describing. And therapy is there, but we have the privilege to be thoughtful of what type of therapy we do, because a kid in the midst of a flare may not respond very well to response prevention and exposure therapy because of how that illness is impacting them. So I tell you this, I think about it of acute stage stabilization and maintenance from a psychological point of view. And that is where my treatment plan was really formulated. What kind of therapy? When do I do it? How do I reach out to the medical people? When do I want them to say, hey, I'm noticing something here. What should we be doing? One of the biggest supports we do as psychologists is actually helping the family with school. Next slide, please. this is similar to the slide that Amy put up. And if you notice on the left side, mood and emotion, cognition, sensory sensitivities, motor movements, are tics, and procedural learning, all of these we look at in formulating what type of therapy we're going to do. In particular, that procedural learning. So when Amy was describing the basal ganglia and how the antibodies are attacking that healthy part of the basal ganglia, it's that it is misinterpreting what it should be doing. Well, guess what? That can have a real big impact on these kids at school, on their procedural learning. For some of these kids, they are actually not learning from the reward predictions system. They are learning from the fear prediction system. And so they're staying in a loop, and they are not doing, like, we're giving them rewards, but they are not really able to do that procedural learning. And I say this because sometimes neuropsych testing can be really helpful. I recently presented to the Florida school psychologist about PANS and PANDAS and neuropsych testing when it's helpful. Remember, there's functional impairment. And one of the things we can do is look at that functional impairment. I have no doubt Sarah's going to talk about functional impairment, because with OT, that can be so valuable of helping that family and that child get back what they've lost in functional impairment. You don't have to do fancy stuff here, folks. You just have to see where is the priority and what are you most able to help with. And I always highlight, if the procedural learning isn't there, they're struggling at school. Maybe they might even withdraw from school. But also in therapy, they're not going to follow you. And so really think about your prioritization. Next slide, please. So, you know, Oprah said, you get a car, you get a car, you get a car many, many years ago. Well, look at us mental health professionals. You get a treatment model, you get a treatment model. We have a lot of fabulous treatment models, and we get to choose which one is going to help that family the most. However, you have to be thoughtful when you choose it. Remember that caregiver burden. Remember that where's the child in their medical treatment? How are they doing? How long have they been in a flare? What kind of support financially, socially, academically do they have? When we look at this slide, we have so many options, so many places to support, but we have to be very judicial in what we choose. What is the symptom? Remember, Angela mentioned it's a constellation. If you only choose one symptom you're addressing, you may then be impacting other systems. So I just say we've got lots of treatments and they're all wonderful, but you do need to be thoughtful of when you choose to bring in that treatment and what it looks like. Next slide, please. The PTEC, this came out from, again, our friends through the Neuroimmune Foundation. They said, hey, let's help families and researchers track the symptoms. It came out this year in 2025, and it's a lot of questions. However, it will look at, if you've ever heard of the PANS 31 assessment, it is 31 behavioral symptoms that we can check off if our client is in a PANS flare or a PANDAS flare. They just made it electronic for families. And I find these families really want to do a lot of research and help other families. It can be intensive, but it can also be a way for us to communicate and see small shifts and small changes and really help the researchers along the way. So I just wanted to give a plug out for that. Next slide. Finally, interdisciplinary collaboration. When you work in this field, you need to be friends with every ologist you can think of, whether it's a rheumatologist, immunologist. Sarah's laughing because I bet she knows so many ologists, occupationologists. Like instead of calling Sarah an occupational therapist, I call her an ologist. Amy, as a psychiatric nurse, she's an ologist. You want to have a really strong team where you can bounce ideas off of, or say, hey, is this kid what they're showing me psychiatrically in a side effect of medication? Is this a side effect of the illness? Is the pathogen cleared? What is going on here? But you really do want open communication. And if you ever want to learn how to build your team, I am always happy to talk about it. I talk about it frequently because one of the kindest things you can do for families is a warm handoff to another clinician, another specialist who says, yes, I have an opening, instead of them having to call 42 people. We really try to ease the burden because these families have a big burden. And I think that's my last slide. It is. So now I pass it over to Sarah.
Thank you, Dr. Lamb. I learned a lot from reading through your slides. Actually, before the presentation today, I actually did the PTEC symptoms list, and I found it didn't take long to go through, but it was helpful for me to not just to get the score at the end and have a now baseline is something to refer back to for medical providers as well. But I thought it was helpful for me to look through how I was rating items and if another person that for looking from the outside in would use the same numbers as I did. So I think that could be a useful tool for providers to give to parents and caregivers. I appreciate you sharing that. My name is Sarah Van Alstyne, for those of you who don't know me yet. And I live near Guthrie, Oklahoma with my husband, James, and our two boys, 18 and 14. And then we also have two dogs, one of whom ended up being a gift at the right time to be a support animal and a snuggle puppy for the kid going through all the medical issues. I was talking with Jadine actually in the lobby of the state Medicaid agency, but we were talking as moms, sharing about our kiddos and health experiences with them. Um, we were wishing that more providers knew about PANS and PANDAS and how we really had been immersed in this new situation years prior, and it was good to talk to another mom that understood what we were going through. But we also both had a background in healthcare, and so it's kind of an interesting perspective too. Um, we we knew that something had changed with our child, and we knew that something was wrong. But a lot of the medical providers, just even well-intentioned, kept telling us that it was fine. Just give it some time. Children change over time, and sometimes symptoms will just resolve. And I think they were trying to, in my case, reassure me that it was going to be okay. But I would much rather have had the curious inquiry to look through the symptoms list. And I did experience, even from somebody that knew me personally and as our pediatrician, uh, to tell me that we needed to put a stricter bedtime routine into place when I was bringing up the insomnia concerns, and who I did feel that judgment of, it's a parenting issue, not a medical issue, but we were trying to explain, and I use medical terminology pretty easily. So that was hurtful from the human perspective as a parent, not to be listened to when we were concerned about behaviors and wondering what to do, to just be told, oh, it's just a behavior. So thank you all for being here to learn about this topic today. It's really important to so many families, including my own. And go ahead and next slide, please. Thank you. So I'm here today first as a parent whose child has PANDAS, but my hope in being here is to share our family's experiences with you. And whether you're a professional, a medical or mental health provider, or whether you're a parent or a caregiver or an educator, someone working with these children in different settings, my hope is that I want to show you that you have support. There are healthcare professionals and other families that are available and want to help you along this journey, no matter what stage of learning that you're in, and whether you have experience with this already or not. So thank you all for being here at this presentation, but also the medical condition is real. You've heard so many good research linked comments about where it comes from, the the medical aspect of it and the psychological aspect of it as well. And so I want to first start out with kind of the parent part of it. That's been shared from several of the presenters as well. But I wanted to let you know how important it is to hear what the families and what the people with this diagnosis are saying, because a lot of times we've been told it's not what we think it is, or that it's not as big of a deal as it is, or that even that the condition isn't recognized yet. So we know that it is, and we thankfully have seen so much more research come out. So it is real. Symptoms can cycle or change, and it is more of a long-term condition than originally thought. So thankfully, the research coming out is helping to support the families who have seen this cyclical or even chronic remitting relapsing condition. So from a family point of view, wanted to encourage each of you to keep learning and then to teach others what you know. So even though I feel like I've learned a lot, the next part of that is to then share what we've learned. And so again, it's a good experience for me to be here sharing this with you today, but also helping other parents when I hear that they've received the diagnosis or that they're looking to get a confirmation of their symptoms, just to be able to support others in this learning experience, in this journey. And then from a mom point of view, do what you can and then rest. I'm not finished learning this yet. I'm a chronically fatigued and sleep deprived mother. And thankfully, my job experience has been such that I've moved into more administrative than clinical so that I have time to take care of this precious child that has extra medical needs right now. And then to be able to rest when I need to so that I can stay up late with him or deal with things in the middle of the night if I need to. And as a parent, who's also a clinician, that was tricky for me to balance my role wanting to take care of and be the caregiver and get all of the things done that I knew needed to be done, but then also educating the school, educating the teachers and the admin on what we were dealing with and how to help and be supportive and follow the law, and then also being a detective and a researcher and looking for the next thing that we needed to do to help him heal and be an advocate. So all of that to say you are not alone. And I encourage families and providers to seek out resources because it's so helpful when you can say, oh, I know somebody who's going through that, and here's the contact information for this support group or for this online research forum where you can find more information. So having the resources to share with others is important for providers and for families as well. Next slide, please. Thank you. If you don't know yet what occupational therapy is, I would love for you to do a Google search, ChatGPT it. But it is based on an engagement in meaningful activities. And that includes a lot that has to do with PANDAs, like self-care skills, education and work access, social interactions and routines of self-care. So especially as an occupational therapist, my eye is already on those things. And so knowing when my son's behavior dramatically changed when he was younger, I knew there was something wrong, but I didn't know what it was at first. Occupational therapy integrates the newest scientific evidence with ancient traditions of healing through engagement and purposeful occupations. For a layperson to understand, really people are much more likely to heal effectively and more successfully when they're engaged in their own care. So that means incorporating the client with the goal setting and asking them to do the things that are important to them with the supports they need. So whether it's a adaptive equipment like a walker or a cane, or whether that's a mental health support, whether we work on routines and scheduling and using adaptive training so that they can get back to the things that are important to them, or whether they need to do things in a new way because of an illness or a chronic condition. That's what occupational therapy focuses on. And we use all of those skills and techniques with human development and neurorehabilitation to help people analyze and problem solve to be successful in their daily life. And so the occupation part of that is there. With all of the things that we do in the clinic as an occupational therapist, The crossover with PANDAS tends to be in the main areas of self-care, feeding, and school and work. So the things that we need to do during the day. Next slide, please. Thank you. And so a rather occupational therapy thing to do, and I'm sure that you may do this as well with your clients, is a storyboard. And so um, after 20 years of being a clinical occupational therapist, I saw my first client that had a diagnosis of PANDAS. And so I did the basic workup to help them get going, but then I needed to do a lot more research about how occupational therapy could help with what I thought was more of a medical condition. And so I learned a lot after that first client. Even after doing all of the research, a lot of other providers didn't believe that PANDAS was an actual bona fide condition. So educating others, even though I was new to this, was still something that I was trying to do from the beginning. And then a few years, about 2 years after that first client, where I really started to learn about what PANDAS was, we realized that the symptoms that my son was having, and this is a stock image for his privacy, but that was the look that we got a lot of the time, was that he needed help and he didn't know how to ask for it. Panic attacks, night terrors, episodic mutism. So we worked out a system where he could text to me, or we'd open a note app on our phone and he could kind of figure out how he needed to explain what he needed when he was going through an episode where he was just so overwhelmed and he didn't feel good and he could not talk. The words were not coming. And that was difficult for me to see because I wasn't sure what was going on and what was happening with him at the time. Food refusals, separation anxiety. We had to have the school resource officer meet us in the mornings to take him out of the car. Sometimes in elementary schools, probably first, second grade, that we were really having a struggle with that. Frequently sick, and a lot of allergy symptoms just showed up. So there were a lot of medical things going on and behavioral at the same time. So I did include some imagery there of a lab because we did a lot of blood work. We went to a pediatrician, we went to specialists. He did go to the hospital once or twice for some special testing. And the school bus is there because unfortunately around that time, then we also had the COVID lockdowns and the schools closed and we went remote. It ended up being a blessing for us because we could modify his learning environment. And he actually did have the chance to heal at home. We were able to do some pretty stringent medical interventions to try to help him get through this initial flare crisis. And then we also learned that he had dyslexia and dysgraphia. So some of the symptoms of the schoolwork degrading had to do with the PANDAS, and some of it had to do with the fact that he was getting up in his second and third grade work and needed supports. The light at the end of the tunnel photo was to show that we did get through that first flare and he seemed to be making improvements. And then whammo, we had a flare up again and we found out that he had Lyme. But it took us several months to find somebody who would do the appropriate testing to find out what it was, because all of the other rheumatologists, pediatrics, inpatient ER testing didn't show anything. We didn't know what was going on. Finally got a diagnosis of Lyme along with some other co-infections. So the mycoplasma pneumonia, the long COVID, a lot of other things were going on in his body. So I added a picture of a toolbox there up in the middle left to show you that even though I felt like I developed tools over the years, it's still a recurring and chronic thing that we keep an eye out for. Even when he's healthy and well, we know that something can come along and his body is just susceptible. Next slide, please. So the research is there and there are so many new things. I even added one little link at the bottom from February of this year that the AAP finally put out some more information verifying with the latest research on PANS and PANDAS. Next slide, please. And then all of the different symptoms is a really great slide to have a lot of them in one place. But some families won't recognize these as a flare symptom because their child has had that behavior or that symptom for another reason, another medical reason. So sometimes these are missed. And if you know what to look for, you can help them go back through that and help them with their timeline and tracking. Next slide, please. These are resources specific to Oklahoma that I thought I would just add in here. Some of these are social media groups. Others are national networks that are really great, that have websites with really great information and offer support groups, online Zooms or remote support group events for children and youth, and then for parents and caregivers as well. We did have our first PANDAS Awareness Day in Oklahoma at the Capitol in 2017. And then the World PANDAS Awareness Day happens every year, and you can find a lot of information about that online and frequently can find some local resources during those Awareness Day events. And again, at the end, I just wanted to say that if providers could increase their ability to take this information with chronic illness, and instead of saying, let's just wait and see, trying to be reassuring, ask some questions, make a list, put the details in the chart, because even though you want to be reassuring, we also need to make notations in the medical chart to help the family to proceed with what they need for medical care. And when we know better, we can do better. Next slide, please. And then for providers especially, there are some really great research links here, and those are included in the slides if you would like to have that information after the presentation. Next slide.
Okay, Sarah, thank you so much. That was awesome. I have not been able to hear information from an OT point of view. So thank you. That was, and your personal experience. So thank you for everyone for sharing their vulnerabilities and helping educate us through it. So we want to leave some time for question and answers, which already isn't very much. So I'm not going to go through every single slide. You can move to the next slide, but really, what do people with PANDAS want you to know? What do we need to know? They want you to know, believe them. If they're saying something, believe them. And then a couple slides down, where it says kind. This is a little experiential thing that I do that we don't have time for, but lead with compassion. As providers, clinicians, OTs, whatever space we have available to us, lead with compassion and curiosity. And I try to say this phrase in like every single presentation, regardless of whether it's about PANDAS, anxiety, diabetes, whatever it might be about. If we aren't in a place of curiosity, we are by default in a place of judgment. And I feel like that's kind of a mic drop moment, because if we are not curious, we've already made a judgment about something, and we might be wrong, right? We might not understand the whole picture. So please be curious. And I think I'm going to end there with that little phrase. And we're just going to allow some time for some questions and answers. You'll have all of these slides with hyperlinks. Again, tons of resources. And we are so glad. I know you're kind of a captive audience, but we're so glad that we've got you captive to give you this information. So now we'll just go with question and answers, and I'm not sure exactly how that's going to happen. Emily, I don't know if you'll have questions from the audience or online, but we're here for another 15 minutes coming your way, hopefully with some wisdom.
Jadine, your microphone may be out of battery, so if you want to turn it back on, if not, I'll bring you this one. The voice from the back of the room. Yeah, so we're going to have to repeat the question so that the folks that are online can hear. Yeah. Questions? There you go, Amy.
You may have already addressed it, but why do flares occur typically? Is it reinfection? Is it the infection never cleared? Just wondering, does it vary?
Did neither one of your microphones work, Janine?
Do you think we should answer?
Now,
Okay.
yes, if you all have an answer, please do. Some of the research I did, I just wondered, when we did antibiotic treatment with Sammy, we thought maybe we just damped it down a bit and it lasted for about 3 months and then it came back. So I don't know if technically that's a flare. I'm really deferring to them because I'm on the very much new learning curve. But any of you ladies, please tell us.
Amy, do you want to take that one?
Dr. Lamb, go for it. I saw your microphone
Okay.
go off.
So in flares, what starts a flare is that the immune system has a response and the neuropsychiatric conditions have to be there. How we measure that the end of a flare, remember, Stanford just used their data, but they were collecting data over time and also parent report. What Dr. Rogers is describing, that Sammy went on antibiotics and for a few months did well, but then it came back. That implies that the antibiotics helped with the current infection, but it didn't do enough to give the immune system a robust and consistent infection. Since he had a response within 12 months, going off of this working definition, he would still be in a flare. Now, it's a working definition. Not everyone agrees. If you go and talk to people at Columbia versus Stanford versus Yale, they might have a different definition of a flare. What I would say as clinicians, what I look at is you track it and you see how many neuropsychiatric conditions are coming back and the level of impairment. But if it's within 12 months, I think of it as we might still be in a flare if we haven't really addressed besides the illness, the immune system. But sometimes it takes a while to get into the ologist. So sometimes you're just doing the best you can.
And that's a really good explanation as well. I wanted to just add from the parent point of view, when I'm tracking my child behaviors and symptoms, we've seen a kind of a pattern where his immune system might be lowered, whether that's from another viral or bacterial infection that he's been exposed to or a stressful event. We were asked to leave a school last year when he got sick with Lyme. We've been doing the admissions process and he had a day on campus and a admissions test to get back to the school he really wanted to go to. For 3 weeks prior to that date, his pupils were dilated. He had insomnia, but he would sleep all afternoon. So his sleep-wake cycles were off. He only wanted to eat comfort food like Chick-fil-A and KFC. So we had to set some rules about also having vegetables and fruit and what his the expectations were, but he was allowed to have comfort foods because we were trying to do a survival mode technique. But there are physical symptoms and behavior patterns that parents, once they start tracking, will start to recognize symptoms of flares. And that can be from either outside source, like you said, or the immune system lowered for some reason, and then the recurrence can happen in our experience.
I was just going to piggyback and kind of say the same thing from a non-parent point of view, but sometimes, when you're giving the antibiotic, you think, okay, good, that's it. And then symptoms get a little bit better, but then again, this is immune mediated. So it's how the body is relating to that challenge, whatever that challenge is. And like Sarah said, it could be stress, it could be dental work, it could be a loose tooth, and then it kind of sounds like ridiculous, and it's not. But remember, like, I've got a kiddo that I work with that this person has probably had 10 rounds plus of IVIG, and literally every 5 or 6 weeks, strep. Oh, strep again, strep again. And so we have an ologist, right? Really looking at why is the immune system operating at the capacity that it is. So there's a lot of different reasons why that might happen.
Hi, great talk, very informative. Just wondering what happens when a child with PANS or PANDAS ages out of the pediatric classification?
Anyone want to take that?
It's amazing how many of these kids outgrow this with puberty, but not all. One of the things that caught my interest early on was the preponderance of people in the 18 to 21-year-old group who did well during adolescence, may or may not have had PANDAS as kids, but did well during adolescence. They graduate, they go off to college. They're in a stressful situation with grades, money, relationships. They may be in a moldy dorm or a moldy old apartment. Christmas time, they come home, they have washed out of school. Everybody thinks they're a failure. They think they're a failure, and they've gotten sick. And it's all of the new things that happen for these kids. Even if they go off to a local university, there's a lot of new stuff. So that's a population that we're often inclined to diagnose, especially in males. We're likely to see schizophrenia because some of these kids become psychotic. So we have to be very careful as kids get older. There are many, many cases of adult onset, 18 and older.
I would like to also add, this is a vulnerable time period for these young adults or going into adults, and the chronicity of some of these illnesses. So remember, some of the flares can be chronic over 35 months. And some of these young adults who aren't diagnosed with Lyme or some other infection or pathogen or other factors, they can really be very sick adults. And so you transition from the pediatric world to the adult world, but there can be a gap in treatments.
Okay, I have actually two cases, but one's a question first. Is that, and this is what I've been told about it, if you have strep multiple times, and then the doctor is given an antibiotic, and then later a steroid, does that have anything to do to cause PANS or PANDA?
Steroids are frequently used in this population for severe symptoms just because it's a strong anti-inflammatory and it's more of a rescue. In severe cases, I don't see it used routinely for kids that fit the mild or just the new onset. When it's not severe, steroids can have adverse effects. But it's a Band-Aid, and it can certainly be used when safety is an issue or if you need to intervene with, I call them the big guns.
So would it be fair to say?
Can I also add on to the steroids comment? One of my clients who is an autistic adult who I communicate with him using a letterboard. He was ill, and I said, this really strikes as a PANS case. He's a young adult. He did antibiotics, but reported, he's like, I'm still foggy brained. And we did steroids, and his speech became more reliable. He responded, he's like, I can tell the difference between my apraxia and my OCD. So steroids can play, like Amy said, a very important role in that more severe. But I do look for cognitions and foggy brainness if they're not responding well enough to the antibiotic.
Okay, if you don't mind, I have one more. I have a second one that has been diagnosed with PANDA. And this child, if you're working with this child, he's going to start jerking with his arms, etc. The next thing you know he's going to do, he will grab a bunch of papers and he'll throw all your papers across the room. He'll go over to the pencil sharpener, take the bottom off the pencil sharpener, throw it at you across the room. What is what we would do with a regular child? Is that still used, or how would you approach that problem?
Hello, anybody?
I'd say
Go ahead.
I think it depends on what's happening. Are we talking about tics? Are we talking about functional neurological challenges in there? Are we talking about, I take a very, when it's challenging behaviors due to inflammation, I typically take a very, for better, for worse, I'll say it out loud, I take a very PDA approach. I just don't call it PDA. The pathological demand avoidance, I call it nervous system overactivation. And I typically go into the PDA style of low demand because they are so dysregulated and so overactivated already. It's like pressing or poking the bear. We need to go at it from a different point of view. But we also, again, lead with curiosity. What is the function? What is the challenge? What's the hard? And then as soon as we gain understanding, then we can decide what approach we're going to take with that kid.
Okay, follow up if you don't mind. So if he starts to hit you in the face, you would say, just block that and then move on? Or what would you do?
I think you're asking some really hard and some really good questions because most people don't want to talk about this real stuff.
I've been there.
This is the real heart of it. Karen, I can see you. You've got your.
This is in the intake part of the work. This is where I do the crisis planning before I need the crisis planning. So I think more of DBT. And I think about, for that family, how do we think about keeping them safe? What are the tools that we need to keep that child safe from themselves, the sibling safe, the therapist safe? Absolutely. We might realize now's not the time to do this type of therapy because the therapy can be really overwhelming based on what we might be doing. Dr. Tanya Murphy here in Florida, she swabbed like 700 kids, and they were healthy kids, and they were kids with strep. And what she noticed is that kids with strep had more disruptive behaviors, which is really, really important. Reminding ourselves this kid is doing the best they can and they don't have impulsivity. They do have inside them the things that should be relaxing or actually excitatory. So then me as the psychologist, I'm thinking, what can I do to be less, like Angela said, less excitatory to their own excitatory. So in these cases, I go DBT.
And neurons are no joke.
I would just like to add, having seen so many of these children in action, that some clinicians have a room that is set up for just this, where the child doesn't have access to things they can throw. There are cases where kids are so dysregulated that they don't need to be in your office. They are just so dysregulated. They need to be in the safest, most stress-reduced situation they can be in. Usually that's their home. I typically see my patients in their home. I do a lot of telemedicine with older kids, with their parents, but these kids I want to see in their home. I want to see them interacting with their siblings. I want to see the parents interacting, because that gives me a better sense of, is this child ready for CBT? Are they stable enough to attend to the tasks of CBT? Are the parents being beaten up by these kids? And I can't tell you the number of parents I have that are black and blue because of these kids. When my kids were going through this, remember, my kids are in their 50s. I was working on adolescent chemical dependency unit and had the benefit of takedown training. When my son was in this situation, I would just come up behind him, embrace him, and we would sink to the floor, and we would sit there until he was ready to not be kicking and screaming. We'd hum, we'd sing, we'd do whatever that worked sometimes. It's all trial and error, but there are kids who are not safe to be in a therapist's office.
Yes, thank you.
And thank you for asking that question. It's really important. I want to say that occupational therapy does a lot of work on the nervous system and regulating and teaching the client and their families how to self-advocate for what their body needs at that time. The tricky part about PANS and PANDAS being they might be able to function at a high level at one day and the next they're not. So having the plan in place beforehand, it might be part of a program for clients and families that have symptoms of this, even if they don't have the diagnosis yet. But even if it's suspected, any kind of autoimmune or neuropsych condition can benefit from an occupational therapy consult, even speech therapy for a backup communication system. At times, I have to switch back to picture stories or even using kind of a modified PECS app, because if he's not able to get the words out that he needs to and is in kind of an emotional state, it's a lot easier for him to communicate with me without the demand of words, of having to work through his emotions and his words if we're working on a basic communication system. And then the next day he might be in a much better place. But for that moment when there's harm at stake or safety is an issue, it could be helpful for you to have some of that training from an occupational therapist report or to have a consult in your office so that you can build a safe space when clients are in a mode where they need that.
Okay, it's working. Excuse my ignorance on the first question. Is there no strep vaccine? And on my second question, is there any data correlating or looking at the relationship of the pediatric vaccine schedule in PANS and PANDAS?
If it's okay, can I ask?
Hang
if-
on, we got it. We got it. Hang on.
Scientists who are working on a strep vaccine. In fact, when Dr. Sweeto identified the disorder, the reason she got in contact with Dr. Cunningham is that Madeline Cunningham was a strep researcher, and their goal was to develop a strep vaccine. They've not had a successful one. Vaccine issues, that is the hot topic. And I would love to know from all of you how you're handling it. I have the disadvantage or maybe the advantage of being 75. I remember kids in iron lungs. You know, I am a pro-vaccine person. However, I do believe that there is a better way for us to deliver vaccines where the risk of an adverse reaction is mitigated to the greatest extent. Vaccines do cause injury. There are researchers, particularly in New Jersey, who are looking at ways to identify that one child in approximately 40 who should not be vaccinated. And my dream is that when we do the newborn heel stick, we'll have a genetic test that will tell us at birth, is this a child that we should have rely on herd immunity? Again, that is my biased opinion, but having lived through all of the epidemics of chickenpox and measles and horrible things that happened to us back in the 1950s, I have a lot of trouble bumping up against parents of the kids that I treat who are totally anti-vaccine. And sometimes we just have to table the topic and leave it up to the pediatrician. But do vaccines cause PANDAS PANS? My opinion is that they don't. Infections cause PANDAS PANS. Now, again, vaccine injuries do occur, and the injuries can sometimes resemble some of the symptoms we see in PANDAS PANS, particularly with regard to expressive language. So that's just my opinion, for what it's worth.
Thank you, Amy. And wanted to just add on to that as well. Sometimes if you already have the diagnosis, it's good for families to be careful about how many vaccines they may receive at one time, because we know that the adjuvants can stir up the immune system. So we need to be thoughtful and mindful about planning for those medical appointments. And then also in current research, the occupational therapy and physical therapy populations seeing a lot of the clients who now have diagnoses of PANS-PANDAS also have connective tissue disorders, which would make it more accessible for bacteria or other pathogens to cross the blood-brain barrier, whereas the typical population can get over strep with or without antibiotics and not see the same sequelae afterwards. So that there is some correlation between a connective tissue disorder underlying the more susceptible that the child may be, or that the adult onset is for, like they mentioned before, even mold exposure. So it's not always strep. And so a vaccine may or may not be a preventative for PANS-PANDAS, but it is something to keep in mind that there are correlations between the different pathogens and this condition. And then immune modulating issues like having injections and different vaccines. They are related, but we don't know the answers to that yet.
I treat a fair number of patients with Tourette syndrome of all ages. And if we just look at the tick symptom in isolation, I'm intrigued at the overlap with the similarity of the age of onset, the waxing and waning of the symptoms, response to low doses of antipsychotics. I'm just curious if there's any other links or comorbidity, or do they get misdiagnosed as Tourette's and then have to go beyond that? Just any thoughts about that?
I'd like to talk about that one. My oldest daughter, when she was 4, she got scarlet fever and she developed Tourette's right after scarlet fever. Now, I lived in Washington, D.C. at that time, and I was aware of pandas 20 years ago. And, you know, it was right after an infection. And it was a really interesting thing. To this day, her ticks are mild, but there are certain things that will flare them up. But there is actually a good deal of research out there about the relationship between all of these things. Dr. Whalen at UCLA, he breaks PANS and PANDAS kids into 3 groups. One of them is the kids who are oppositional. Another one is the like classic OCD kids, and the third one is the motor movements, the Tourette's. I also am CBIT trained, but sometimes I don't think we are trained well enough to make that correlation between illness and Tourette's, and I think we should do a better job. So I don't know if that answers your question, but there is quite a bit of research out there to say, hey, we should pay attention to this differently.
I think it's important to note that one of the criteria for PANDAS is a temporal association with strep. So there has to be, for that diagnosis to fly, for a child to meet the clinical criteria for a diagnosis of PANDAS, there has to be a temporal association with strep. And that is often used as the differentiator between Tourette's and PANDAS. Prior to Dr. Sweeto's work, kids with tics were diagnosed with Tourette's and treated. My daughter nearly died of a clonidine overdose because my husband and I both medicated her and didn't check with each other. But that's all we had back then was clonidine. She had 11 vocal and motor tics at the same time, diagnosed with Tourette's, turned out to be PANDAS, but it was before Dr. Sweeto had done her work. So it's hard. It's very difficult. You have to take all the things into consideration.
Well, I think our time is up. We're going to take a break, but a couple of questions. Okay. Couple more. Okay. Yeah.
Thank you for your presentation. I'm scrolling back through my database of children that I've seen over the years and where I may have missed this. And so one of the things that I'm thinking about is, this is not my wheelhouse, and this is new information for me. When I'm going to assess this, using the PTEC, is that what you'd recommend? And so help me clarify that, my first action item of whenever I'm suspecting that this may be your wheelhouse. Where is my first action item? And then who do I refer to for additional support and where I can give to my parents?
I would say this is your wheelhouse. And what I would say also is you can refer to sometimes the pediatrician or the medical person who is in your client's life, just to start to get an idea of what's going on medically. Now, the PTEC is helpful to collect data, but it is not what I would say is helpful for your assessment. And if you would like, if I can get your email, I will email you an example of an assessment with some questions that you can ask. Because when I was trained, I was just trained to say, is this OCD? All right. Were the symptoms, were they an abrupt onset? That's all I was trained. And I've been doing OCD work for over 20 years. But what I've learned over the years is we actually have to be a bit more thoughtful about our questions. And going back to that word abrupt, what does abrupt really look like? Has there been illness in your family? Who's been ill? How long have they been ill? Some people can be asymptomatic strep carriers in families. So if somehow I can get your email, I will send you a cheat sheet of some questions that you could add in there into your clinical interview.
I am so glad Dr. Lamb mentioned the fact that there can be a strep carrier in the family. We've had numerous situations where a child visited grandparents every 2 weeks and would always come home and develop a flare. I know of 4 cases where it was the family dog that was the strep carrier. And the veterinarian treated the dogs for strep, and the kid got better. So strep is ubiquitous. I had a dinner party one night and I had 2 wonderful pediatricians sitting around my table. Somebody asked me what I made a mistake of asking me about my job. And these 2 pediatricians said, well, all kids get strep. End of discussion. So sometimes you have to push a little bit too. And my parting words are listen to the moms. If mom says there's something wrong, listen to the moms.
Dr. Lamb, if we can ask that you email us that assessment form, then we'll make sure and put it on the website for the conference, if that's helpful.
Sounds good. I'll email it.
And
And-
Dr. Rogers?
Oh,
Go ahead.
sorry. I was
Go ahead,
just going to
Dr. Lamb.
say, if there are resources, if you want to know about RFID, if you want to know about just a comprehensive handout to give to your families, Aspire, which is on the screen down there, they have some wonderful handouts that they have created to make your job easier. If you have trouble finding Aspire, just email me. My email is at the end of the presentation. I am not kidding that I probably have like 300 articles and things that I've gained over the years, and I'm always happy to share them because I think everyone in the audience is equipped to do this work and we need you.
So Dr. Rogers, I believe that we are running just a little bit behind, but I know there's been folks that have been sitting. So if we can take just a real quick 5-minute break, then we can get the next presenters and we can get going. Everyone give us a big round of applause.
I just want to say
everyone.
thank you to our panelists. Wonderful, wonderful information.